Dear colleagues, welcome to WeOncologists and ESO Presents. My name is Gilbert Morgan. I am the WeOncologists part of this joint venture with the European School of Oncology. And we come to you every week and we take over your cell phones and tablets with your permission. And together we learn and expand our oncology knowledge. And we do this with the hope that we can spread quality oncology education globally. In turn, we hope that patients globally will benefit. We initially started this as for oncologists, by oncologists. Nothing has changed. We still have the same mission. We still have the same format. However, we have a large number of patient advocates and oncology nurses that now follow us. So to them, we extend a very warm welcome. We want to remind everyone that next week we have our Palliative Care Week. We are going to be streaming 3 lectures through Twitter and Facebook, and we do this in the hopes of focusing more on palliation, as I personally believe that any good oncologist is going to be excellent at palliative care. So without further ado, I would like to introduce today's speaker. This is Dr. Manuel Maia. He is from the Centro de Oncología de Paraná. He did his medical oncology fellowship at the Instituto de Cáncer in São Paulo. He did his research fellowship at City of Hope Comprehensive Cancer Center under the mentorship of Samantha Pal. And his current practices focuses mainly on GU malignancies. He will present for us today the best of ASCO GU 2019. So, Dr. Maia, please take it away.
So, hello everybody. Thank you for joining us for this presentation. I'm very honored to be here today. I would like to thank Dr. Jill Morgan for the invitation and for this great initiative. I think this is really important for us as young oncologists to get together, increase connection, and share knowledge. So I'm really honored to be here, and I hopefully will address my content satisfactorily. And I hope this is good for you guys. So my name is Manuel Maia. I will talk to you about best of ASCO GU 19. These are my credentials. I am a medical oncologist that currently practice in Brazil, Curitiba, and I'm a former research fellow of GU from City of Hope Cancer Center in California under the mentorship of Dr. Samantha Pal. And I'm also currently a member of leading American competitive group in GU. These are my disclosures. So the way I designed this presentation is I selected a few important abstracts from each day of the meeting, and I will use authors' slides to show the data, but at the end of each abstract, I will provide my own slide with some perspectives and some comments, and hopefully this is gonna look good. So day 1 was a day focused in prostate cancer, and the first trial I'd like to comment on is ARAMIS trial. So ARAMIS trial was a phase 3 study assessing the safety and efficacy of darolutamide in non-metastatic castration-resistant prostate cancer patients. So what's new about darolutamide? So it is an AR antagonist, similarly to enzalutamide and apalutamide. However, it has a distinct structure in the way that it has less CNS penetration and potentially causes less CNS toxicities. So this is the ARAMIS trial design. As you can see, patients were randomized to receive darolutamide, 1,200 milligrams daily plus ADT, or ADT plus placebo. Patients enrolled were patients with non-metastatic castration-resistant prostate cancer by conventional imaging. This is very important. And with PSA doubling time less or equal to 10 months. So the trial design was very similar to what we saw last year in the Prosper and Spartan trials, which tested enzalutamide and apalutamide in the same scenario. The primary endpoint was metastasis-free survival, and overall survival was a secondary endpoint. So this is the primary endpoint, metastasis-free survival. We can clearly see that there is a separation of the curves in favor of darolutamide, reaching more than 40 months median metastasis-free survival. So hazard ratio 0.41. This is a 59 risk reduction of distant metastasis or death. So this is really, really important. And the primary endpoint was met, as you can see. As a secondary endpoint, however, overall survival, although we see a separation of the curves and the p-value looks positive, it did not meet the pre-specified criteria for significance according to the authors. So this endpoint was not met at this point. Data is still immature, but however, with a longer follow-up, potentially we will see a benefit here. In terms of other secondary endpoints, time to pain progression was significantly improved with darolutamide, time to cytotoxic chemo, and time to first skeletal event was almost significant here. It also did not meet the pre-specified criteria for significance here, but there was a trend also. These are the adverse events of special interest. I would like to highlight here that in terms of fatigue, there was a 5% more fatigue with darolutamide compared to placebo. But if you take a look at dizziness, cognitive disorder, memory impairment, seizure, you don't clearly see a difference between darolutamide and placebo. So that's what the authors were trying to see, if there is in fact less CNS toxicity. And in fact, it appears very similar to placebo. So, and also in terms of bone fracture and falls, no clear difference here. So nothing really concerning. As conclusions from ARAMIS trial, it really met its primary endpoint, reaching over 3 years of metastasis-free survival. Overall survival, however, is still pending. The efficacy data is very comparable to what we've seen with enza and apalutamide, potentially less toxic. And a consideration, however, is are we really treating non-metastatic castration-resistant prostate cancer patients here? I don't think so. I think we are treating metastatic patients. We just don't see because we are utilizing conventional imaging. So for instance, last year at SUO meeting, an abstract was presented and Spartan-like patients were enrolled and they were staged with PET PSMA, and over 55% of the patients had distant metastasis detected. So I think this is just something to bear in mind. These patients are more likely metastatic, as you can see. So day one, prostate cancer, we'll move on to the second abstract, which was ARCHES. So ARCHES was a phase 3 study assessing enzalutamide or placebo in the castration-sensitive setting, metastatic prostate cancer patients. This is the ARCHES study design. Patients were randomized to receive ADT plus enzalutamide or ADT plus placebo. And in terms of stratification factors and inclusion criteria, I think this is very important to highlight that it enrolled some key patient populations that were either underrepresented or not represented at all in other similar trials. So it included both low and high volume disease patients. It allowed prior dose Taxol therapy for metastatic hormone sensitive prostate cancer setting. And it also allowed patients who were relapsing after local treatment. So this is very important. In terms of primary endpoint, radiographic PFS was its primary endpoint, with overall survival as a secondary endpoint, along with other important secondary endpoints, as I will show. This is the baseline patient characteristics table. This is just to show to you how many patients had high disease volume here. 62 to 65% of the patients high disease volume, meaning 35% patients had low volume disease. Distant metastasis at diagnosis, 63 to 70%, and prior dose Taxol almost 20% in each arm. So the primary endpoint, radiographic PFS, there was a clear benefit in favor of enzalutamide here. hazard ratio of 0.39. It was a significant improvement in radiographic PFS, as you can see. This is a subgroup analysis of the primary endpoint. We can clearly see that the benefit was seen across all subgroups, including low and high volume disease and prior or no prior docetaxel therapy. This is the overall survival data. This is only an interim analysis, so you don't really see a clear difference between the curves here. They kind of start to separate after 21 months. However, data is still very immature to take any definitive conclusions here. There is a trend, however, in favor of enzalutamide, but a longer follow-up is needed. This is another secondary endpoint, time to initiation of a new antineoplastic therapy. You can see that enzalutamide prolonged the time to initiation of a new agent, hazard ratio of 0.28, and it was also significant. And if you take a look on the right-hand side, here you can see which therapies were used after progression. So if you take a look at the placebo group, 133 patients received a new therapy after progression. And in terms of percentage, you can see almost 40% utilized docetaxel, 21% utilized abiraterone, and 21% utilized enzalutamide. I think this is not still ideal. I would like to see more patients crossing over to receive enza or even abiraterone here, since both are they target the axis. And I really think that if you want to test a drug that is known to improve survival in the castration-resistant setting, if you want to test this drug in an earlier stage, you really need to allow patients to cross over after they progress. Otherwise, you can never answer the question whether utilizing at an early stage is really more beneficial than keeping it for a later time. So although it's quite low in my opinion, it could have been improved, but it is still higher than what we saw in Latitude, as I will show to you later on. This is putting the data into context. This is a table comparing the trials in the hormone-sensitive setting here: ARCHES trial, Latitude trial, Stampede, and Charted. In terms of primary endpoint, we see that ARCHES had radiographic PFS and not OS as the primary endpoint, which were included as primary endpoint in the other trials. So this is an important consideration. And in terms of prior docetaxel, ARCHES was the only trial that allowed prior docetaxel use. So this is very important. If it comes out with a positive for overall survival later, then you can really have now an evidence to support using enzalutamide after prior docetaxel therapy. And in terms of de novo metastatic patients, 67% were de novo metastatic patients in the ARCHES trial, meaning more than 30% of patients were relapsing after local treatment. This is also a key patient population that were underrepresented in other trials. For instance, Latitude trial did not include patients that were relapsing. Stampede trial only included 5% of patients that were relapsing after local treatment. Although you see 49% here, this is because Stampede, for instance, included also non-metastatic patients in the intention to treat analysis. But if you take a look at the metastatic patients, the number of patients who were de novo metastatic patients were more than 95% of the patients. So really, relapsing patients were underrepresented in the other trials, and that's why it makes it an important consideration for the ARCHES trial. So as a conclusion, the primary endpoint was met, radiographic PFS. However, overall survival data is still pending. It's important to understand again that key patient populations were included, and the benefit was seen across all subgroups, including low and high volume disease, previous docetaxel use, and patients with relapsing disease. Moving on to the last abstract of Prostate Cancer Day, Latitude trial. This was an update of the Latitude trial. You probably all know Latitude trial, which was a phase 3 study assessing the role of abiraterone plus prednisone against ADT plus abiraterone and prednisone compared to ADT alone in patients with high-risk metastatic castration-sensitive disease. This is the trial design. Patients were randomized to ADT plus ABI plus prednisone or ADT plus placebo. And important to show here the exclusion criteria: patients with low-risk disease, patients with prior docetaxel or prior localized treatment were excluded from this study. And in order to be considered high risk, patients had to have at least 2 out of the 3 criteria: lesion equal or greater than 8, 3 or more lesions on bone scan, and measurable visceral lesion. The primary endpoint was overall survival in radiographic PFS. This is the first interim analysis reported in 2016. We saw that overall survival was statistically significant, improved with the abiraterone added to ADT. Here, at that point, median overall survival had not been reached. And in terms of radiographic PFS, at the first interim analysis, we could also see that there was a clear benefit with abiraterone, 33 months against 15 months in terms of radiographic PFS. And now this is the final analysis presented this year. Overall survival now with mature data, we can see that it reached a median overall survival of 53.3 months compared to 36.5 months with ADT and placebo. So clearly there is a benefit for this intervention here. And we saw that almost 17 months longer overall survival compared to the control group. Very impressive results. These are the final analysis of secondary endpoints. Abiraterone improved time to pain progression, time to skeletal related event, time to chemo initiation, time to subsequent prostate cancer therapy, and time to PFS2. This is a post-hoc analysis of the trial. So the authors analyzed overall survival, stratifying patients according to disease volume, utilizing a charted definition. Unfortunately, they did not see an overall survival benefit when they looked at low volume disease patients. It was not statistically significant, although there was a trend. However, on the left-hand side, you can see that among high volume disease patients, there was a clear benefit. It was in fact statistically significant. They did the same. They run the same analysis in terms of radiographic PFS, high versus low volume, and you see that low volume derived a benefit in terms of radiographic PFS, although less benefit, but it was statistically significant. So this is a very important slide here that I'd like to call your attention. This is a table providing the numbers regarding the utilization of other life-prolonging therapies after progression. So if you take a look on the right-hand side, in the placebo group, only 57% of the patients received a life-prolonging therapy after progression. This is really concerning to me because I think this number should be really higher than this. And if you pay attention to how many patients utilize ABI or ENZA, you see that less than 30% received ABI or ENZA after progression. So again, this is really concerning to me because if you really want to show a benefit of utilizing abiraterone at an earlier stage, you need to allow patients to cross over to receive it. Otherwise, you're not really answering the question. So this is my concern with this trial. Very low crossover. So in conclusion, latitude trial, we see an improvement in OS and radiographic PFS. Caution, however, there was a limited crossover to ABI and ENZA. We could see in in terms of benefit among low volume disease patients, a radiographic PFS benefit. However, in terms of overall survival for low volume disease patients, it was not significant in a post hoc analysis. However, bear in mind that STAMPEDE showed a significant benefit among low volume disease patients. So now moving on to day 2, which was a day focused in bladder and testicular cancer, and I selected 2 trials to present. First one is IMMU 132. So this trial tests the safety and efficacy of sacituzumab govitecan in patients with previously treated metastatic urothelial carcinoma. It was a phase 1/phase 2 study. So what's interesting about this compound? This is an antibody drug conjugate that is directed at TROP2 protein, which is highly expressed in many solid tumors, especially in urothelial carcinoma cells. And what it does is once it binds to the protein, it releases intracellularly cytotoxic component called as SN38. So just for the record, SN38 is the active compound of irinotecan, a chemotherapeutic agent very common in GI malignancies. And the good thing here is that it delivers actually more than 136-fold CNN38 compared to irinotecan. So very high concentration into the cells. So this is the study design. This was a phase 2 cohort expansion, included 45 patients with metastatic urothelial carcinoma. Patients received 10 milligrams per kilogram of sacituzumab, which was a dose defined in the dose escalation phase 1 trial. It was applied in day 1 and day 8 every 21 days. The primary endpoint was response rate. So this is just to show the demographics of the study. Patients were heavily pretreated here. Patients with up to 2 lines comprising 62% of the patients, and 3 or more lines, 38% of the patients, heavily pretreated. So in terms of objective response rate, we see that patients with up to prior lines showed a response rate of almost 40% here. And patients with 3 or more lines, a response rate of 17.6%. So really, really impressive here. In terms of adverse events, main concern here was neutropenia, with 22% of the patients presented with grade 3 neutropenia, 16% with grade 4 neutropenia. However, only 7% developed febrile neutropenia. However, this is something to bear in mind. A lot of patients had to use G-CSF in order to control neutropenia. This is the PFS and overall survival of the trial. Median PFS of 7.3 months and overall survival of 16.3 months, which is fairly good for a heavily pretreated patient population. This is a comparison with other trials designed in the second or third line. These are all the trials testing immunotherapies, which are all approved as second-line agents for this disease. You can see that in terms of overall response, it ranged from 13.4% to 21.1%. So in terms of response rate, this new compound actually is impressive. And this is a comparison with other novel agents in development for urothelial carcinoma. As you can see, there is here erdafitinib and enfortumab, sacituzumab, and the combination of ramucirumab plus docetaxel. If you take a look at the response rates, really sacituzumab has a very high response rate, and it's comparable to what we see with erdafitinib, which has been just approved by the FDA as a second-line option for FGFR positive patients. And in terms of PFS, the trial also shows a fairly good PFS here. And also in terms of overall survival, it showed the highest overall survival compared to other novel compounds. So it's a really impressive compound, although this was a very small study and needs longer follow-up. This is really something that can change the treatment scenario for heavily pretreated patients. Oh, sorry. Something must have gone wrong with the last slide, but in summary, this is a promising agent, although very small trial, need longer follow-up and randomized data to really test its activity. So moving on to the second abstract from day 2, the PRIMETEST. So the PRIMETEST was a trial assessing the role of surgery in terms of primary retroperitoneal lymph node dissection in stage 2A or 2B seminoma in patients without adjuvant treatment. So the trial design the authors included patients with seminoma stage 2A or 2B, meaning less than 5 centimeters in diameter. Patients were recurring during surveillance or after one cycle of carboplatin, and they had normal tumor markers. The treatment strategy was open or robot-assisted surgery, and this was a phase 2 trial designed to enroll 30 patients, and the primary endpoint was recurrence-free survival at 3 years. This is, however, the report of the interim analysis, the first interim analysis. So only 14 patients were included in this interim analysis. As you can see, 6 patients with stage 2A and 8 patients with stage 2B. And in terms of recurrences, we could see at this point 4 recurrences, meaning 29% recurrence rate with a mean follow-up of 12 months. And what was concerned to me was that out of the 4 recurrences, 3 were in stage 2A, which is highly unexpected, in my opinion. And all these patients after recurrence were treated with BEP, chemotherapy. So the recurrence-free survival at this first interim analysis was 71%. The trial had established a threshold of 30% in order to move on. So since it was 29%, they are moving forward with the trial, right below the bar. So in conclusions, I think we should see these results with caution. Surgery is still investigational for this scenario. Many recurrences were seen even in stage 2. So chemotherapy for stage 2B and radiotherapy for stage 2A are still the standard. So now moving on to the third day, which was focused in kidney cancer. I also selected 3 abstracts here. First abstract was Keynote 427, Cohort B. So this trial tested first-line pembrolizumab monotherapy for advanced non-clear cell RCC. So this is the background. Why this is important? Well, non-clear cell RCC is an area of unmet need because the only available treatment strategies consist basically in VEGF TKIs, and usually patients do poorly. They do not respond as well as clear cell patients. So there are only a few treatment options for these patients, and new drugs need to be developed. This is the trial design. The trial had a cohort A comprised of clear cell patients, which was presented last year at ASCO. But today, we'll focus in the cohort B, which is the actual presentation. So patients were included if they had non-clear cell RCC, they were treatment naive, and they were enrolled in a single-arm trial testing pembrolizumab. And the primary endpoint was overall response rate. So in terms of characteristics, I would like to highlight the histologies included. Papillary consisted most of the patients. followed by chromophore, and followed by classified. And in fact, this is what we see in the practice. Papillary is the most common non-clear cell histology in practice. And in terms of overall response rate, we saw approximately 25% response rate in the overall population, almost 5% complete response rate with pembro alone. In terms of response rate stratified by histology, we see that papillary derived a benefit of 25% response rate, chromophobe less than 10% response, and unclassified patients with almost 35% response rate. This is the median PFS, 4.1 months, and median overall survival not reached here, although 72% of patients were alive at 12 months. So in conclusions, I think this is a very interesting data in terms that it validates the utilization of pembrolizumab in this patient population. However, bear in mind that this was not a randomized trial, so sometimes we are surprised. It seems very beneficial, but when you do a randomized trial, the benefit is not that much. So randomized data would have been preferred here. And but another interesting thing is that if you compare these results with those achieved by VEGF TKIs alone in the first line, they're not clearly different. So I would not say that pembro showed a very impressive result here. I think this is going to be a treatment option potentially, but I would still go probably, if the patient can tolerate it, I would still probably favor VEGF TKI for these patients. So moving on to the second study, which was the Calypso. Calypso was also a trial testing a novel strategy among non-clear cell patients, and it investigated the safety and efficacy of savolitinib and durvalumab in papillary metastatic renal cell carcinoma. This is the study design. Metastatic papillary RCC patients were enrolled, 42 patients. Patients could be either treatment naive or treatment refractory, and they were assigned to one arm involving savolitinib, 600 milligrams daily, plus durvalumab, 1,500 milligrams every 4 weeks. So just for the record, savolitinib is a MET-specific inhibitor TKI, and durvalumab is an immunotherapy, a checkpoint inhibitor. And the primary objective was response rate. And in terms of response rate, the 27% response rate in all patients, and a bit higher response rate of 32% when considering only untreated patients. In terms of biomarker analysis, the authors did this analysis in terms of biomarker. So among PD-L1 positive patients, we saw a response rate almost 40%. And on the other hand, when you look at the right-hand side in the blue bar, only 20% of response rate among MET-positive patients. This was not done with mutation analysis. Actually, MET positivity was assessed with immunohistochemistry, which in fact is not ideal. So MET positivity with immunohistochemistry analysis is not very good to sort out if the disease is really MET-driven. And in order to define if the disease is really driven by MET mutations, the mutations should be analyzed. So not very informative, this immunohistochemistry analysis. In terms of overall survival, median overall survival of 6.9 months, and in terms of median PFS, 5.3 months. So in conclusion, I think a longer follow-up is needed. Of course, it's only a very short follow-up, and however, I would like to say that I'm not impressed by these results. I would expect more from this combination. It's good to see that there are many other combinations being tested within non-clear cell histologies. However, you don't really see an additive benefit of durvalumab over savolitinib alone. And if you really also compare these results with those results of VEGF TKIs alone in papillary kidney cancer, you don't really see a very a big difference. So in my opinion, no additive benefit and no obviously synergistic benefit. So now moving on to the last abstract, Keynote 426. So Keynote 426 was a very important study assessing the role of pembrolizumab plus axitinib versus sunitinib as a first-line treatment for clear cell renal cell carcinoma. This is the study design. Patients were randomized to pembro plus axi or sunitinib alone, and the dual primary endpoint was OS and PFS. And all IMDC risk groups were included, including favorable, intermediate, and poor risk patients. Patients had to be treatment naive. So this is the baseline characteristics, just to show you that over 30% of the patients had favorable disease, risk disease, 55% intermediate disease, and 13% poor risk disease. So in terms of overall survival, we can clearly see a separation of the curves here. It was very significant, hazard ratio 0.53. The median overall survival was not reached with the combination and neither with the sunitinib alone. In terms of progression-free survival, we see a hazard ratio of 0.69 in favor of the combination, and the median PFS was 15 months compared to 11 months with sunitinib alone. In terms of secondary endpoints, objective response rate, we can clearly see a very high response rate for the combo, almost 6% compared to 35% with sunitinib alone. However, if you break down the responses, you see that there was almost 6% complete response rate with the combo compared to 2% with complete response rate with Sutent. And also very important to consider in terms of primary progressive disease as the best response. You see 11% of the patients with the combo presenting with primary progressive disease compared to 70% with sunitinib alone. So really very good data, and in fact it has just been approved by the FDA for first-line therapy among advanced RCC patients. And I think this is very attractive, especially for favorable disease patients, which although were included in the CheckMate 214, they were not included in the primary endpoint. And in fact, when we did an analysis in the CheckMate 214, favorable disease patients did not derive the same benefit in terms of PFS and OS compared to sunitinib and compared to intermediate and poor risk patients. So favorable disease patients were lacking a new treatment strategy, and in my opinion, pembro-axi data validate its use among these favorable disease patients. And another consideration is that when you compare these data to ipi/nivo, you have a higher response rate, almost 6% compared to 42% with ipi/nivo. But in terms of complete responses, we see less complete responses with pembro-axi. 6% versus 9%. So this is another thing to bear in mind. And it's not clear at this point which combination should be used. If you consider, for instance, intermediate and poor risk patients, there's no clear winner in my opinion. I think both strategies are okay. And one consideration is, since it has a higher response rate and a lower primary progressive disease rate compared to ipi/nivo, then pembro-axi might be more attractive for patients who need a very fast and higher response rate. So that's my take here. So I would like to thank you very much for joining us in this presentation. I'm available for other questions if you may have through Twitter, or you can